Good evening, everyone. Good evening, everyone. I would like to welcome you all to the TCAC Prostate Cancer Awareness Symposium. My name is Brother Dr. Truman Warren. I'm a member of the Tau Macron Lambda chapter and seated in Brazoria County. Today's topic is Prostate Cancer Awareness Symposium. It's a symposium over prostate cancer regarding early detection and lifelong protection. And I would like to introduce our moderator for tonight, Brother Arthur Gregg. Brother Arthur L. Gregg is the owner and CEO of Gregg Training and Consulting located in the Dallas Fort Worth Metroplex. Gregg is known for his presentation and workshops on topics ranging from leadership and leadership development, diversity, equity, and inclusion, the multi generational workforce, college readiness, recruiting, and retention of underrepresented minority students. He is an active member of the Zalta Lambda chapter of Alpha Alpha Fraternity Incorporated. Now I turn it over to you, Brother Greg.
Thank you, Brother Warren, and good evening, everybody. We're so glad that you're here, and I'm excited to be your moderator. I'm not going to be long. We're going to jump right into some ice cold facts. But before we do that, let me introduce our next speaker, who is none other than Brother Dr. Kevin Moses. Dr. Kevin Moses is the Associate Professor of Urology at Vanderbilt University Medical Center, and he's the Director of the Comprehensive Prostate Cancer Clinic. He is a Phi Beta Kappa graduate of Morehouse College and received his MD and PhD training at Baylor College of Medicine in Houston, Texas. His clinical practice focuses on advanced prostate cancer, including several clinical trials, as well as surgical management of the advanced renal, penile, and testicular cancer. Dr. Moses' research is focused on addressing health disparities in urologic cancers, determining the role of health literacy and patient interactions with the healthcare system, and optimal care for patients with metastatic and or castrate-resistant prostate cancer. Wow, Brother Moses, that's heavy. Give us some ice cold facts.
Well, thanks so much. I appreciate uh, Brother Derek Williams, his invitation back, and to everyone in Texas. I spent 9 years in Texas, so I have a lot of love for my Texas brothers and everybody there. So I'm gonna jump right into it. I'm gonna share my screen. Um, all right, so here we go. So prostate cancer, ice cold facts. And so I'm going to talk about screening for prostate cancer, which I feel like is probably the most important step, how we diagnose this, and then the treatment options if you are diagnosed with cancer. So here's where the prostate is. And I show this not to be graphic, but a lot of times men will come to my clinic and where's the prostate or why are you doing that exam down there? And so this is where it sits. You see the bladder just above it. The urinary channel goes through it and it sits right in front of the rectum. And so that's why when we do the exam, we can feel the backside of the prostate when we do that. And what the prostate does is it produces a fluid that helps break down semen so that the sperm can do its job. It also, like I said, is part of the urinary tract. And so that's why as men get older, it gets larger and sometimes causes urinary symptoms like a slow stream or trouble getting the bladder all the way empty. So prostate cancer is very common. It's the most common solid organ in men, solid organ cancer in men, and the second most common cause of cancer death in the United States. And in Black men, it is extremely important. We have the highest incidence in the world, Black men in the United States, and have double the death rate from prostate cancer compared to white men in this country. And despite that, Black men are less likely to get screening or treatment. And so that's why events like this are extremely important. And when I talk about screening, we're talking about PSA, which is the blood test, and the DRE, which is the physical exam where we feel for the prostate. And those two are complementary tests. Now, right now, when we say screening, there are different guidelines from national panels that give recommendations. The American Urological Association says we should start talking about and doing screening at age 55 to 69, and we'll start earlier for Black men and those with a known family history, and that means a brother or dad or uncles. And then you can continue screening in men older than 70 if they're in excellent health. The NCCN, and I'm actually the chair for this panel, we set the screening from 45 to 75 and then down to 40 for Black men and those either with a history of prostate cancer or the breast cancer gene in their family, known as BRCA. Now, we do recommend you can spread out screening over time if it's a very low PSA, and then it can also screen in very healthy men older than 75. The United States Preventive Services Task Force is what most primary care doctors follow, internal medicine and family practice. And they too say you should discuss screening starting at age 55 to 69, but they do not make any accounting for Black men or those with family history. And there are several groups that are working on getting that remedied by them. So, what is a normal PSA? And most people will ask, well, my PSA is less than 4, so that means I don't have cancer. And that's not necessarily true. There's really no firm cutoff for what PSA means you do have cancer and don't. And that's why it's a little bit of a controversy. You have to take into account a man's age. Does he have an enlarged prostate, which can make the PSA go up? And then the reason for screening and getting your annual testing is you can follow the trajectory. Is it a nice, smooth, slow increase over time, which is normal? Or do you see a sharp curve upward at a specific point? And so what that means is a PSA of 3 in an 85-year-old man is not nearly as worrisome as a PSA of 3 in a man in his 50s or 40s. And so that's why we have to take some accounting of other factors. And if your PSA is concerning or an abnormal exam, then the doctor may recommend a prostate biopsy. So what do you do if the PSA is elevated? Well, if it's slightly elevated and it's been rising a little bit over time, you can just repeat that number and confirm, is it truly going up? If there's evidence of prostate infection, then you should give antibiotics and then recheck once that infection is clear, because that can cause a really sharp rise in the PSA that should come back down with antibiotics. But if it truly is elevated, most people now will recommend a biopsy, and then the vast majority will recommend an MRI before, so you can get a picture of what the prostate looks like. And this is what an MRI of the prostate looks like. And where that T is where the tumor is located in the prostate. You see there's kind of a dark wedge as compared to the lighter crescent around the prostate. So that would be a concerning lesion. And the point of getting the MRI is number one, if there's no lesion, then you feel a little bit better about maybe there's no cancer. But if there is one, you can specifically target it so that you can get a more accurate biopsy of the prostate. And this is how a prostate biopsy is typically done with an ultrasound. That probe does go in the rectum so you can get a good view of the prostate. We inject numbing medicine in specific areas so that the biopsy should not be painful. And then when we're doing a typical sampling, you see here on the right, we typically will take 12 biopsies, 6 on each side in specific regions of the prostate to try to get a good sampling. Now, I mentioned the MRI because you can do fusion biopsy where the ultrasound images are merged with the MRI images, and you can get a very accurate picture of the prostate, but also, again, go after specific lesions. And that machine will calibrate the MRI with the ultrasound, and you can target very specific areas. And these are the two most used platforms, Urinav and Artemis. Once that biopsy is done, it's sent to the pathologist. They look under a slide and they say, is it cancer or not? And then they give it a grade. And usually within a prostate, there's two different patterns, and they'll add those numbers together. So if it's all uniform Gleason 3, which is typically the lowest number, we don't typically see Gleason grade 2 anymore, then it'll be a 6. If it's all just really aggressive cancer, it'll be a 10. Or if it's somewhere in between, they'll add those numbers together and give you a number somewhere between 6 and 10. And if diagnosed, then we stage you, meaning we determine the risk. Is it a very aggressive cancer, like a high risk, where the PSA is very high, the Gleason number is high, or a very abnormal exam? Or is it low risk, meaning the PSA is low, the Gleason number is low, and a normal exam? Or is it somewhere in the middle? And what that means is, particularly for high risk or sometimes even really aggressive intermediate risk, we will also get a CAT scan and a bone scan, or sometimes a PET scan as well. And that's because the higher the risk, we want to make sure that the disease has not spread or become metastatic. So, what do you do if you're diagnosed with prostate cancer? Number one, don't freak out. Okay. The number one thing is educate yourself and talk about your options. Okay. Now, we can do watchful waiting, and this is really best for older men, really, older than 80, 85, whatever, they somehow get diagnosed, or men who have a lot of other competing comorbidities, uncontrolled diabetes, uh, severe dementia, other cancers that are metastatic or spreading. Because in those men, any kind of treatment is going to decrease their quality of life significantly without any additional lifespan because you somehow treated their prostate cancer. On the other end is for men who are diagnosed with metastatic disease, that it is a hormonal disease. And so it should be treated by blocking testosterone. And so we give androgen deprivation therapy. And usually it's given by shots every 3 or 6 months. You can remove the testicular tissue. And there's also a pill version now that can be given that can help prevent the spread. Now, metastatic disease is not curable, so I'll go back to saying really you should focus on screening so that if it is detected at an early stage and can be curable. Okay. Now, for men with and I see the questions and I'm gonna answer them. Okay, I see you, brother Bruce. If you have very low risk or low risk cancer, meaning low risk of death or symptoms from prostate cancer, there are ways of avoiding treatment because not all men with prostate cancer will die of prostate cancer. And so we can do what's called active surveillance, which means we avoid treatment in men who will not have fatal or symptomatic disease. But if the disease does progress within the prostate, it can be treated in a timely manner and still be cured. And the typical way that's done is you check PSAs every 6 months, you repeat biopsies every 1 to 2 years. And if there's any escalation, then you can go ahead and get treated. Now, active treatment comes basically in two big umbrellas. One is radiation treatment and one is surgery. And there's different flavors of radiation therapy. Most commonly done is external beam radiation or what's called stereotactic body radiation, SBRT. There's 3D conformal, IMRT. There's also radiation seeds that can be implanted directly into the prostate. And in some men with higher risk, you can combine brachytherapy with external beam radiation or external beam radiation with hormone therapy, again, depending on how aggressive the cancer is. This is what it looks like. This is the machine. You'll get what's called a simulation. And this is the picture that they generate. And what they do is get a very specific outline of the prostate so that you're treating just the prostate and avoid damage to structures that are close by, like the rectum or the bladder. And then the other big umbrella is surgery. Very few people do open surgery anymore. I'm one of the few that do it in my region in the Southeast. The vast majority are now done robotically, robotic assisted prostatectomy. This is what it looks like for a radical open prostatectomy. My incision isn't quite that long, but in the lower part of the abdomen. And what you're doing is you want to remove the prostate. And as you can see again, it's between the bladder and the urinary channel. So then you have to hook those two back together. Now, this is what radical robotic surgery looks like. So the surgeon is sitting off to the left, controlling, looks almost like the referee at a football game. And then to the right here is the arms that are attached to the patient. And then there's a bedside assistant who's helping you. This is where the arms are going in, and this is the kind of view that you have. It's very magnified, it's 10x magnification, it's a 3D picture. And so you can get very good control of the nerves that help control erection, the muscles that help control urinary function. There's some other therapies, not maybe quite for prime time or for very specific indications, but you can do cryotherapy, which you're freezing, usually just the area where the tumor is located. HIFU or high intensity focused ultrasound is another one that uses ultrasound waves to basically boil the tumor. And then for metastatic disease or very advanced, there's several big categories: chemotherapy, immunotherapy. There's actually a vaccine for prostate, and then other hormonal therapies. Now, whenever you're treated, you still have to continue to check PSA because there's always that risk of cancer coming back, especially if you're intermediate or higher risk. And that PSA going up, sometimes you can just watch it if it's going up slowly, but if it's going up quickly, you can do radiation if you've already had surgery. You can do surgery after radiation, but it is more difficult. It definitely has a lot more complications. And then there are medications that help block testosterone, as I mentioned before. In surgery, there's always risk of incontinence because the muscle that you help control your urine is very close. And so the older you are, the worse function you have before surgery, there's higher risk afterwards. And almost everybody leaks after the catheter comes out, and you have to strengthen that muscle. If you ever heard of women doing Kegel exercise after a baby's born, we teach men to do Kegel exercise to strengthen that pelvic muscle. And that risk is about 10%, and it's lower in younger men and higher in older men. And then the other is erectile function. The age and your pre-treatment function are important. Most men lie about their erections, especially after a certain age. And so, they think they're playing with a pool cue and they're playing with a rope. And you got to be honest about where you are because that lets us know where you'll probably be after surgery. Again, younger men probably can regain most of their function if you could do nerve sparing. But older men or those that you can't spare nerves, you're almost certainly going to need medication or some other intervention to help with erections. Now, with radiation, during the treatment, things like burning or frequency or diarrhea usually get better after the radiation ends and are usually pretty manageable. The effect on your continence and erectile function is much less with radiation, which makes sense. But there is a slightly increased risk of bladder cancer and colorectal cancer long term over time. And so you have to be monitored for those. The good thing is, the vast majority of men do not die of prostate cancer. And so we talk about survivorship because you got to learn you got to live with it, but you got to maximize your living, your quality of life. So the first thing is educate yourself. Get good, reputable materials. Don't go to IHateDrMoses.com. It's going to be full of bad information. Okay, you got to go to reputable sources, and I've listed a few here. Talk to family and friends. Now, it is good to know um, uh, if other people have been through that journey. I say eat healthy and exercise and really do that now before you get any problems, right? So eat good lean meats, avoid fried foods, avoid packaged food, fresh fruits and vegetables, exercise. Those are the things that help you live longer, even if you're diagnosed with cancer. And don't be afraid to ask questions. I'm gonna get to the questions that are in the chat, and I see some good ones already. So let me uh, Moderator, do you want me to go ahead and answer questions now, or do you
Let's
want to
let's
read
take a
through
few, and if
them?
we're not able to get to all of them, we will save the questions and get with you to get them answers. As long as we have the brothers' names and we can get back to the brothers or those who have asked the question. But let's go ahead and jump in on the first question.
Yep. So, Brother Bruce said, why are black men more likely to have aggressive prostate cancer? And how does that influence how we interpret PSA results? And that is an excellent question. Um, there's a lot of research on why. I have my theory. Um, if you look at Japanese men who have some of the lowest risk of prostate cancer, you look at Japanese men who immigrate to the US, their risk almost doubles. And then if you look at first generation or the children of those immigrants, so Japanese Americans, their risk is almost that of white men. So there's something about being in America. There's something about the environment, the diet. I think it is an inflammatory cancer. It is a stress cancer. Because you see similar trends in Black women and breast cancer. Um, and so I think that has an influence. There are some data that show that Black men or West African men do have slightly increased risk if you look on a worldwide scale. But even us compared to Caribbean Black men, we still have a higher risk. So there's something to do with that. Again, for normal PSA, there's really not a great number for that. You really need to use the trend. I do view an elevated PSA a little bit different in black men. So again, that if it's one or two or three, but they're in their 40s or 50s, I'm going to view that or sort of go after that much more aggressively because I know of that risk. And then I'll go into the next question kind of goes into what I was going to say about family history. If you know your father, your brother, your uncles, what are called first degree relatives, that basically doubles your risk. And that goes across the board. First degree relatives doubles your risk for prostate cancer. And again, most of the guidelines will say start screening either around 40 or 45 because of that.
All right. So we got the next question is coming from um, D. Cheney. Is an elevated PSA over 2 years with a negative biopsy okay?
Yeah, so that's reassuring. Having a negative biopsy, the chance of a deadly cancer after an initial negative biopsy is very, very low. Um, I would say continue to check your PSAs, and you really want your PSA. They need to graph it, okay? And they can do what's called a velocity. How fast is that PSA rising over time? And as long as that velocity is relatively slow, and especially if you know the prostate is very large or enlarged, then that is definitely reassuring. But if that curve, let's say the curve is doing this, and then all of a sudden it starts going up like that, then I would repeat that biopsy because now the trajectory has changed. Instead of a nice smooth curve, you've gone into an upward trajectory.
Awesome. Thank you. So, are you familiar with the cyber knife treatment for prostate cancer? And this is from brother for Christian Stevens.
Yeah. So CyberKnife is a great option for brain cancers, head and neck cancers, and for a lot of pediatric cancers. CyberKnife data for prostate is very, very weak. Um, it is owned by practitioners, and so they advertise heavily, and they will make claims that they can't back up with data. And so I'll say at Vanderbilt, our radiation oncologists do not use CyberKnife for prostate cancer and actually recommend against it. That being said, a lot of men do get it. You can, it is very precise, and so you can avoid a lot of symptoms. But as far as cure for prostate cancer and long-term control, the data is not there yet. Um, uh, I have followed various men who've had CyberKnife before. Um, so I don't necessarily wholeheartedly discount it, but I would say the data, especially long-term data for prostate cancer, is relatively thin.
Thank you. So, Brother King wants to know of the two mentioned exams, which is most effective? And does age factor in which exam?
hmm So I always say it's complementary. Most of our guidelines will say you can just do the PSA and use that as sort of the first screen. But if you're going towards a biopsy, at a very minimum, you should get the exam because again, that can indicate a nodule. A lot of people have gone away from doing the rectal exam and getting the MRI because you can see abnormalities in the prostate with that too. But a nodule that's felt on exam can be very informative when you're doing your biopsy. So I say it goes together. You don't necessarily have to do it from the very beginning. Start with the blood test, but the combination of those will indicate, the risk.
Thank you. So our next question says, I had an ablation a couple of years ago to treat enlarged prostate. Is there
Mhm.
anything I can do to prevent it from becoming enlarged again? Talked about the urologist has visited once a year,
Mhm.
and he's been very vocal about the experience. Wants to help out in Dallas and getting the word out. And anything that you know of, anyway. So let's start out with the first part of that
Mhm.
about the enlarged prostate.
Yeah, so there's a lot of ablative therapies for prostate, and that's typically for urinary symptoms, right? So slow stream, incomplete emptying, urinary infections, bladder stones, any of those kind of things. And they're very effective. The prostate does continue to grow as you age, and you can get regrowth. Um, I don't have the data for it. I do suspect that prostate growth is inflammatory, and as a low inflammatory diet, I feel like will help with that regrowth. Now, there are medications that can help with prostate growth and actually shrink down the prostate, but they do have side effects. So I would caution that they're very effective, but there are some side effects that go along with it. But really, that focusing on that dietary and drinking plenty of water, making sure you're emptying your bladder all the way are going to be the best things. As far as the second part, Brother Derek Williams is on the phone. He's very active in the prostate cancer world in the Dallas area. The organization I work with that I listed is called Zero, Zero. And I know there's an active chapter there as well. And then I know who's the pastor that huge church in Dallas? Ralph West, is that the name? Friendship in Dallas.
Uh, uh, Freddie Haynes.
Freddie Haynes?
Oh, is it Freddie Haynes? Yeah. So I know Friendship has done like men's health or health fairs before, and they've had prostate cancer. So I would, some of the faith organization leaders may have those, but there's definitely some active chapters in some of the prostate cancer support groups.
We're going to ask a couple more questions. We got a panel to come up. So, brothers, if and I guess if you have questions, if you've asked a question and we don't get to your question, if you would please restate your question and put your contact information, we will summarize those questions and get them to Dr. Moses and get information back to you. So, thank you, brother Gilmore, for sharing about the Kegel exercise. Let's see correlation between heart disease. Is there a correlation between heart disease and ED?
Definitely, definitely. So sometimes ED is the first symptom of something going wrong in the heart before chest pain, before high blood pressure, before shortness of breath. And it's all about small blood vessels, right? A heart attack is just a blockage of a very small vessel in the heart. And ED means that you're not getting good blood flow, which is typically because of narrowing or hardening of the arteries that feed into the penis. And so a lot of urologists who do sort of like holistic treatment will have you see a cardiologist if you have new onset ED, just to make sure you don't have coronary disease. So definitely um, a potential association there.
Thank you. So, how does smoking cigars after surviving prostate cancer, or in smoking cigars or smoking in general, affect the reoccurrence or prostate
Mhm.
cancer at all?
So I'm gonna ruin a lot of brotherhood smokes, but even if you don't inhale you're still absorbing nicotine and a lot of the toxins that are in tobacco. And any cancer, there's higher chance of recurrence with any smoking, any kind of tobacco consumption. So that means the Zen packs, the dips, the chews, the vapes. Um, none of them are good. None of them are good.
So,
So yeah,
I mean that, but it is what it is, right?
it is what it is. Yeah, it is what it is. And um, yeah, I've ruined a lot of brotherhood smokes. I'm sorry.
So, brother Theo Tanner asks, have not heard anything about proton therapy. Is
Yeah.
it recommended?
So same thing. So proton and cyberknife, I would say the data is weak on it. Proton is great for head and neck cancers and pediatric cancers. A lot of people would do proton therapy, but the data is there's no great long-term cure rates with proton compared to external beam or surgery.
We're gonna take one more real quick. Please, brother, if and guess if you have asked a question, if you got we don't get to your question, if you put your contact information along with and restate your question, we'll get that information to you. Um, can you address the myth that in some cases a biopsy can cause cancer to become more aggressive?
Mhm. Yeah, I get that question a lot. So biopsy doesn't spread cancer, and it doesn't make it more aggressive. The needle track um, is so there's a sheath on the needle, and then the part that biopsies into the prostate withdraws back into that sheath. So as it comes out, it is protected. Um, there have been case reports of cancers along needle tracks and other cancers like kidney or liver, but I mean you can count, you know, 5 or 10 out of tens of thousands that are done every day all around the world. And so the risk of a cancer is going to be far, far, far outweighing any risk of needle track spreading. And it certainly doesn't make it more aggressive. Now, it may be that the biopsy missed a more aggressive cancer. And so that's sometimes we'll do repeat biopsies, but it doesn't necessarily cause a more aggressive cancer. But that's a great question.
Brother Moses, thank you so much. You have, I mean, just the questions alone, the knowledge that you put out, those ice cold facts have been awesome, brother. So, if you would mind dropping your contact information in the chat, so brothers want to, our guests want to hit you up, send their questions directly to you. Thank you so much. We appreciate it. And I don't know if you're going to hang around for the panelists, but you're more than welcome. And again, it's always good to know, like they say, know before you go.
Thank you. Yeah, I'll stay on.
All right, thank you, brother.
And I put my email in there for the questions.
Awesome, thank you. So we have some awesome panelists up. We're going to start out this year. We're going to talk about really a little bit more so on our panelists of how prostate cancer affects the family. And so first up, we have Brother William Noble. We'll let him tell you a little bit about himself. He's going to share his testimony and how prostate cancer has affected him, he and his family. Brother Noble.
Hey, good evening, everyone. Again, my name is William Noble. Crossed at Epsilon Lambda, fall 2001. I'm currently a member of Zeta Lambda here in the North Dallas area. This story is pretty much about my father. He died of prostate cancer. He was, one of those old school people who didn't believe in going to the doctor. He grew up in a time where he just didn't, in a time and in the area in South Arkansas where he just did not believe in going to doctors or trust anything that they said to him. So he kept that faith and belief throughout his entire life. Went to the military and done all the military things, and then he came out and just worked and had a family and just was a hardworking man. Didn't believe in taking days off of work. Didn't believe in any of that stuff. So he later on in life, well, he was also a heavy smoker. So I pulled that in too. So a lot of stuff that Dr. Moses was saying, I was kind of just sitting there thinking, I wish my dad was alive now to hear those things. And maybe the he could have went to the doctor earlier in life and got detected rather than just waiting um, to when he did go. And some of the reasons why he actually ended up going to the doctor was some of the things that Dr. Moses described. later on in life, he couldn't, he was always going to the bathroom. He got very weak. His diet was poor. He had quit smoking by the time that, he got older in life. So he had pulled off the smoking aspect, but he still did not eat correctly. He was bad diet. He never exercised, anything like that. So as he got older, the symptoms, started getting more and more, and he was always tired and lethargic all the time. So when I would call and check on him or come home and see him, I was like, hey, pops, you good? He was like, oh yeah, I'm good, boy. I'm just kind of tired, or I need to get some rest. And he was always sitting down, always tired. But when he was younger, he was always on the go, always doing things, always out in the streets, helping people, doing odd jobs for people and around the house, and just at work. Had a couple of jobs, he always worked. So to see the decline in him, it it really affected me. And it was once he finally went to the doctor, it was pretty much too late for him. And so he just pretty much went really within a few months of discovering he had prostate cancer to going strictly into hospice care. And so that decline and to see the family pretty much taking care of him year round. I mean, around the clock. My mom, she was an older lady, so she was taking care of him around the clock. When he had, you know, I had a couple of half stepsisters, I'm sorry, that they would come over and take care of my father or be with him or help him do stuff or help my mom out in the times when she was just so tired that she's like, I just couldn't do it anymore. So to see that, it really affected me. And I was like, hey, once he passed away, my next checkup at the doctor, I went, was talking to him, was doing my routine checkup. At this state, I was 38 years old. I went to get my basic routine checkup from my doctor, and he was telling me what all he's going to go through and do. And, he looked at my last results from the year previous and was like, hey, you're a healthy guy. All your tests are good. All your blood work is good. This would just be a regular routine test. And I asked him, I said, hey, what about the prostate? And he said, well, normally, if we don't have any issues, you probably won't have to get that checked till you're 45. And I said, well, hey, my father just passed away of that. I want to go ahead and get this test done now. So he included that. And yes, I really wasn't expecting the exam, but I had the exam where they did the physical exam on me, and he also did the blood work. So he was like, hey, I do the physical exam and I do blood work. And so once he did the exam, I was like, okay, like I said, I wasn't expecting that exam, but he did it. And I was glad he did it because now he had a basis for the physical examination and he compared it to what the blood work says. So with that being said, yearly when I go to my doctor, ever since I've been 38, I've been getting that test. And so currently right now I'm 50. So I've been getting that test yearly ever since then. And so once I peaked around about 47, as like the Dr. Moses said, my PSA started elevating. And so then with my history, my urologist was like, hey, we need you to come get it checked every 6 months instead of once a year. So I did that for a couple of years, getting it checked every 6 months. And then it kind of got high, but it kind of went down. And so I've been pretty consistent in the twos ever since then. But it went to me changing my diet, me getting more exercise, me doing more water intake, just me being more active and being cognizant of what I'm putting in my body to try to help out, with these PSA levels or get my prostate more in check. So as Dr. Moses said, and as I will contest again, please, everybody, get your prostate checked. Yes, I understand that the exam is something that we don't really want to do, but coming from a person that dealt with it and seen their father decline at a rapid rate, it was something that I really don't want to go through myself or see that in anybody else. If you could prevent it, get it checked early, get it checked often. If you get it checked early, it's, as doctor said, is easily curable or correctable or can be alleviated. So, hey, tell all your brothers, you go out there and get it checked. If any ladies on the line, Tell your husband, get it checked, your boyfriend, your brother, your cousin, your uncle, tell them all to just go get the prostate check. And, like I said, education is the key. Go out there, educate, tell others to get it done because it can be prevented if you get it checked early and follow through and do the correct treatments and things of that nature.
Well, thank you, Brother Noble. Thank you for sharing, and thank you for sharing your testimony. Brother Eric Williams, you're a survivor. Tell us a little bit about your treatment, your road to recovery.
Absolutely. Thank you for the opportunity. Brother Eric Williams here, and I was 54 years old. I was receiving testosterone therapy. And along with that therapy, every 3 months, you're tested, your PSA levels are tested. And in October of 2023 is when my journey began. It was my second PSA elevation in 2 years. The first time it was treated with finasteride. My numbers normalized, but the second spike, we got a little bit more aggressive. And I had the MRI that Dr. Moses mentioned, and it indicated that I had stage 1 cancer. Following the biopsy in February of 2023, that's when I was diagnosed with stage 2. And at that time, I was given the 3 options that Dr. Moses outlined. One was active surveillance, where you basically just watch and wait. The second was external beam radiation therapy. And the third option was prostatectomy. Took some time over a couple of months, talked to a lot of brothers who had been in my shoes, from, again, active surveillance all the way to radical prostatectomy. After doing some of that research over a 2-month period of time, I chose the radiation therapy, which meant 28 rounds of radiation. It was 5 days a week. I had the weekends off, which was a good thing. Had lots of energy while I was going through the radiation therapy. But when I got to that 28th round after I had rang the bell, is when my energy level just decreased drastically. Um, it took several months from July 11th is when I rang the bell. I got more active around February of 2025 this year, where I was back into my regular schedule of exercise, golf, working out, hanging out with the fellas. Um, and I have to say that I'm extremely, extremely grateful for my wife, my 2 daughters. That was a big conversation at the beginning of our journey is, hey, when do we tell our children? Not if we tell them. Because I grew up in a family, we had lots of different cancers and everything was kept quiet away from the kids, myself included. Lost both of my parents to cancer. Found out very late what was going on. So I missed time that I could have had. And I didn't want to put my family through that same situation. So we brought our girls in and end up being a godsend for me because they were very encouraging, very positive. It was a diet change, not just for me, but for my family. They made sure that I was coached prior to my appointments. They went along with me and encouraged me along the way. Set up a lot of fun things, believe it or not, as we were going through that journey together. And that really strengthened me beyond the therapy. The medical team was amazing. The multidisciplinary team was truly amazing. I'm grateful to have worked for an organization at the time that allowed me to take that 13 weeks off to focus on myself because I was given the option of you can go through this therapy and go to work every day, or you can stay home. I was grateful to be with an organization that allowed me the opportunity to stay home and really focus on me 100%. And happy to say that my last PSA check, which was about 4 months ago, my starting PSA was at 4.54. And at that appointment, it was down to 2.57. And my next appointment is coming up in November, and I'm expecting it to also be at 0 when I can say officially that I am cancer free. But I've been walking as I'm cancer free up to that appointment. But like the brothers have said before, I can't stress enough to talk about it, break the silence, speak up for sure, talk to other brothers that have been through it, that are going through it. You never know what your encouragement may do for a brother that's going through it. Someone said to me, you will rise again. This is totally, death is unavoidable. I'm sorry, this dying from prostate cancer is 100% avoidable. If we get screened, we know our numbers, and share the word. So thank you, brothers, for this opportunity. And I'll turn it back over to you, Greg.
Thank you, Brother Williams. And we're definitely praying and championing you and surrounding you as well. Brother Elmer Corbin, another survivor. Tell us a little bit about your journey and your treatment, maybe your journey, and where you are now. How are you now?
Great. So thank you. First of all, I want to thank everybody. It looks like we have a lot of participants on the call, which is fantastic because this is a extremely important topic for our community. And I'm just so grateful to see so many people that are tuned in to hear this information. Dr. Brother Moses, I just can't thank you enough for sharing this incredible information that you've shared with us, because I'm sitting here just listening to you and it just brings up all of the memories of when I first got that diagnosis back in 2021. So I was 58 years old at the time. And for my entire life, I'd gotten nothing but gold stars every year when I got my annual checkups. And so as you can imagine, it came as just a tremendous surprise to me to hear the doctor say that your PSA is all of a sudden spiked. It went up by more than 1 point from year to year. And so that was the alarm that was set off for me to go get the biopsy. So I went and got the biopsy, still not expecting anything or expecting to hear any bad news, of course. And when I got that biopsy about 3 months later, the doctor walked in and said, hey, bad news, we did find cancer. And I mean, everything just kind of went blank then for me, to just hear that word that you have cancer. It just kind of sent me into a state where I really didn't know what was next. But it was very fortunate that, I have a line brother of mine that's actually a urologist. And so, the first person that I talked to about this was him. And, he gave me a lot of very valuable information that Dr. Moses has shared with you guys today about all of the treatment options and, the Gleason scores I shared with him. He gave me some information that he shares with his patients on a daily basis. I talked to a lot of the brothers that we have within the chapter who also had already gone through similar types of treatment. And, like Brother Williams, Brother Derek Williams, he kind of took me under his arm and said, hey, I've been through this. And so, I can give you all the information that you need about what the next steps are and what you can expect. And, even he helped me kind of go through that decision process about which option I was going to take. So just extremely thankful for, all of the people, all of the brothers who kind of surrounded me and said, hey, we're there for you. And, you're not in this alone. My family, of course, were just tremendous when I shared the news with them. And as Brother Eric Williams said, I was kind of afraid to share this with my kids, first of all. But, my wife was like, no way, we've got to go through this together. And so, I shared that news with them right away. And so they all rallied behind me as well. But my message to you guys is everybody that's on the line, I hope we do have a lot of women on the line as well, because, you got to share this information with your husband and all of the men in your life to just encourage them to get that annual exam. Because like I said, 57 years of gold star reports meant nothing when I got that diagnosis. So it was an unexpected thing for me, but it is what it is. And, going through that surgery was probably, it saved my life, definitely. As Brother William Noble shared with you guys, if you wait until it's too late, then, bad things can happen. So I'm just really thankful that, I had all the people in my life who could. I also had a brother-in-law who had gone through it as well, and he was extremely helpful for me. He was a support system for me as well. And so I just encourage you guys to lean on the people in your life. If you do, once you go through your exams, and if you just so happen to get the diagnosis, you've got a lot of people who are there for you. And it's not a death sentence if you catch it early enough. This is definitely a survivable disease, but you got to get those annual exams and you got to take action when you find out. So my message to all of you is, I'm thankful to be here, and I hope that you guys take something away from this that helps um, to kind of comfort you, that it's okay to get those annual exams. You're not guaranteed to get bad news, but if you do, it's a survivable thing. And, the people that we have on the call, Brother Eric Williams and Brother Derek Williams, and all of the other survivors that are on this call today are testimony, that it's not a death sentence when you get this information. So just take the necessary steps, lean on the people that love you the most, and you'll get through this just like we did.
Brother Corbin, you summed it up. I couldn't do it better. Sum it up. You summed it up. From what I hear you say, and all of our speakers, get tested. Don't be afraid. Don't be ashamed. Don't be shy. Don't go and have those exams. Support. Support is important. Share with your family. Share with others who have gone through this. Allow yourself to give support and receive support. Um, and don't let the conversation stop here on the Zoom. Don't let the conversation. This is just the beginning or a touch on the conversation of all of this that we've talked about tonight. Begins for some people the conversation. Don't let it stop here. Continue. We've posted Brother Dr. Moses's email address is in the chat. I'm going to ask our survivors and Brother Noble if you want to drop your contact information in the chat for anybody who wants to reach out to you. For all those our guests and brothers who posted questions in the chat, thank you so much. If we didn't get to your question, we will get an answer out to you. But a special thank you goes to the TCAC Health and Wellness Committee, Brother Dr. Truman. Brother, I just went Warren and your committee. Thank you for providing this, along with Brother Derek Williams, of course, Dr. Moses, Brother Moses, our speakers, and definitely our district director who really said, "Hey, we've got to do this program." So thank you all so much for being here. Large turnout. Any last words from our speakers tonight before get ready to close out?
I would just reiterate, get the screening done. Don't be afraid to talk about it. This is it's an intimate cancer, right? Like it's something that deals with the most uh, important functions as a man. And so that's why a lot of people are scared to even think about it versus talk about it versus get checked. But get checked. We're at high risk. Get educated. There's no reason to be on the sidelines with this one. Know about it and get ahead of the game.
Any other words? Well, brothers, guests, thank you so much for tuning in tonight. This is just the beginning of a plethora of workshops that will be a series that are coming out from all the different committees in TCAC. Thanks to our district director, Brother Adrian Escalante, We have one that's coming up first of next month on public speaking. It's October 6th at 7:06 on the power of your voice. Speak with confidence and inspire with clarity. And that's coming out from the Professional Development Committee. So, brothers and guests, thank you so much for joining us tonight. Follow up with our guest speakers. Follow up with Dr. Moses. Follow up with our district director. But more importantly, go and get that screening done. And not just one. Do the complete screening, not just the blood work, but the physical one as well. Am I right, Dr. Moses? All right. Thank you so much. Everybody, thank you all so much for tuning in tonight. Thank you for joining us. We look forward to seeing you at all the rest of the programs. And again, don't let this conversation just stop here. Continue the conversation beyond tonight. We'll see you on our next workshop. Thank you very much. Have a great evening.